Good afternoon, everyone. I'm pleased to introduce our speaker, Dr. Christie Bartels. She is the chief of the Division of Rheumatology within the Department of Medicine. Within ICTR, she serves as the Academic Advisory Council lead for the Dissemination and Implementation Launchpad. She seeks to reduce health differences and improve cardiovascular health and longevity of patients with inflammatory diseases. Her research includes several prior pragmatic studies that have been funded by the NIH, CDC, and the Department of Defense, Rheumatology, and the Rheumatology Research Foundation, among others. She is a fellow of the American College of Rheumatology, chair of the ACR Registry Committee, and is a member of the College of Physicians. So we are very pleased to have Dr. Bartels join us today. Welcome, Dr. Bartels.
Thank you, Teresa. Appreciate the introduction. And it's great to see the names of so many friends on the attendee list today. So lots of folks on this list who have equal, if not more, experience in this realm. So I'm looking forward to a robust conversation after today, too. So first of all, everyone can see the slides as we get started here. All right. Glenn, I see your face. Can you see it? You got it? You got slides? All right, excellent, perfect. All right, great, excellent. So, coming up with a clever title for some work that spans many years, but essentially, pragmatic magic. That I started off as a health services researcher doing predominantly just descriptive studies, and have transitioned over into thinking about how to test and examine interventions at scale, kind of thinking about what the population impact is, either to single site or multi-site study. And I thought I would tell that story today, and then I'm looking forward to some good discussion afterwards. So we'll tell you a little bit about that narrative as we go through today. To kick us off, we'll define the role of dissemination implementation science. We'll talk a little bit about why pragmatic studies for learning health systems and learning health specialties are particularly relevant, and you'll see an illustration of that through the talk today. You'll see early on that I'll share some EHR studies that we did early in the realm of RA, inflammatory disease, cardiovascular disease risk, and health equity. And then we'll take it home with two good examples of larger scale multi-site pragmatic studies that we've done, and share those findings and designs with you here today. So, again, people on this call are familiar with the translational pipeline. And really what I would like to focus on is that I really do kind of more of this T3, T4, thinking about interventions at practice and interventions at the population scale. So you heard earlier that I also help with the American College of Rheumatology's registry. We've got 48 million patient encounters here across the US. And again, I'm always thinking about how to solve problems both within generalizable contexts of academic centers or community center settings, but also sort of at scale across our specialty. And so, when I became a rheumatologist, we had fabulous medications that were really dramatically changing the lives of patients with diseases like rheumatoid arthritis, and yet patients with RA and lupus were still dying about a decade or so before peers, and it was usually from heart disease. So that's how I got first interested. Over time, I got particularly interested also in those health differences in outcomes in lupus, which are still daunting us. And so again, you'll hear some stories of how we tackled some of those problems. D&I, in general is just when we study how to get proven research interventions and practices into real world settings. So again, those real world settings are where we test a lot of our interventions and think about implementation strategies that can scale and sustain change. I wanted to just start off again, just thinking a little bit about just the traditional RCT we think about, our traditional clinical trials, and distinguishing those from pragmatic studies. And so, when we think about a traditional clinical trial, really the question we're trying to answer here is, does it work in ideal conditions, right? So we're really selective about who gets in. We deliver it with a lot of high fidelity in a really controlled environment, and we focus on, some pretty well-defined outcomes that are pretty specific, often a single primary endpoint. In pragmatic studies, often we're answering the question of, would it work in usual conditions, right? Like, would it work in a usual care setting? So the nice advantage is we can have a broad swath of participants. We can actually deliver the intervention in a simulated usual care environment, which is beautiful. And then we can also look at lots of different outcomes. So we can look at, how feasible is it in that setting? We can look at what are the efficacy endpoints, and we can, again, get a combination of those. The other piece I want to distinguish here is that when people think about quality improvement, again, quality improvement, if we think about the scope of that, really looking at a local solution to a local health system or a local clinic, it's asking kind of how to do that. It's not really trying to create generalizable knowledge, but both traditional clinical trials and pragmatic clinical studies and dissemination implementation science in general are looking at generalizability. We're looking at how we can do these things at scale to improve the health of populations and outcomes. All right. So as we talk today, I'm going to share a little bit in some examples from RA, some examples from, which is rheumatoid arthritis, some examples from lupus, and then we'll see two examples. One talking about cardiovascular disease prevention, and the final one talking about how we're doing some studies that are trying to improve health equity with pragmatic studies as well. So to kick us off, I thought I'd just anchor us first and just, some of my early data used big data, used claims data, actually, and then we also started using EMR data. And if we think a little bit about it, the nice thing about EMR data is it's got some granularity in it. And I got a couple studies nested here to tell you like why EMR data was actually the data of choice for this question. So one question I had was, is it possible that just having rheumatoid arthritis makes people sort of miss the boat in diagnosing your hypertension as one of your early markers of cardiovascular disease risk? And to do that, we actually made an inception cohort of 14,000 patients who met blood pressure criteria with more than two consecutive visits at greater than 140/90, and just asked the question, how does having a diagnosis of rheumatoid arthritis affect your likelihood of getting a diagnosis of hypertension? Having someone just name that, call that, and address that in a clinical encounter. And we said that naming it counted as either a code for hypertension or a medication for hypertension. And what you can see here is that it wasn't just having multimorbidity. Lots of different conditions actually increase the likelihood of someone calling your hypertension. For instance, if you'd had AFib or you had diabetes. But for instance, rheumatoid arthritis here on the left, you can see made it significantly less likely that someone would call your hypertension, so that we may be just missing the boat on early risk factors. So here, if we think about it, Medicare claims data, which I had been working in, would not have had blood pressures, wouldn't have been able to answer this question. But here we were able to answer the question that patients were less likely to have someone just identify their high blood pressure as a cardiovascular disease risk factor over and above their RA, which we knew is also an independent risk factor. So that was one of our first steps in just kind of illustrating the role of EMR data for questions like that. In lupus, one of the pieces of data that, again, right in that era where we were getting great meds to treat rheumatoid arthritis, unfortunately, at that point, we were still sitting with just one, or at the present, I think, again, fewer than 6 FDA-approved treatments for lupus. And what we knew that in the lupus landscape was that there had been a landmark study showing that there's patients, young women with lupus, ages 35 to 44, for instance, were 50-fold more likely than peers to have heart disease. So this is kind of incredible, right? To have an acute myocardial infarction between the ages of 35 and 44 as a woman is otherwise pretty unheard of, but somewhat commonplace in patients with lupus. And we wanted to know if that also would be seen this was a cohort from Pittsburgh. We wanted to know if that also would be seen here in Wisconsin. And to answer that question, again, we looked at EMR data, and at this time we actually used the Marshfield Clinic data. And Marshfield has the advantage that Marshfield Clinic has a very low migration of their population. About 90% of their population stays in that area long term. So we were able to identify new cases of lupus diagnosed between 1999 and 2008. And here's another little fun fact is that they actually have EMR data going back into the early 90s, which again makes this a unique cohort. And we were able to look at incident cases of lupus and then to examine when patients developed cardiovascular disease relative to their lupus diagnosis. And really our question was, what is the disease burden and what is the timing in patients with lupus compared to matched peers? So Marshall was a great partner to look at this question. And we found, and some of you maybe heard me tell this story before, is that actually our table one, where you're just describing demographics, was actually one of the drum roll findings of the study. That essentially, when we looked at table one to say at baseline how many patients had cardiovascular disease before their lupus diagnosis, it turned out that patients were fourfold more likely than matched age and sex matched peers to have had prior cardiovascular disease, right? Or almost fourfold. So 3.7 was the odds ratio for that. Prior stroke, fivefold more likely. So boy, it looked like those events were happening not only at increased frequency, but actually really early in disease course, which raised the question to us whether there were diagnostic delays or whether this was really just a fast risk that is accrued in patients with lupus, which really kind of turned a traditional dogma on its head, where we thought of that as a chronic risk. So that was, again, another place where EMR data was really incredibly helpful to look at these pieces. And that finding has been subsequently replicated. It's been replicated in this study by Dr. Shivani Garg here, who is one of our fantastic investigators in rheumatology, with Dr. Sam Lim at Emory. And this is the Grady lupus cohort from Atlanta, Georgia, where again, they saw this incidence of cardiovascular disease events starting 2 years before lupus diagnosis. And this has also been replicated in data out of Canada. So again, important factor there, thinking about cardiovascular disease risk early in lupus and thinking about prevention strategies there. The other thing that this study highlighted was that the risk was 18-fold higher in patients of Black race. So again, raising questions of health disparities and differences in health outcomes. So this is an interesting finding as well. All right. And again, those time points, again, the risk was started 2 years before and then continued even 2 years after and all the way up to that 10-year mark. When traditional dogma had said that most of the events would happen after 10 years, we saw lots of early events. The next place that we looked at EMR data to have, again, offer different data than we might see with traditional claims-based data and Medicare or VA data or things like this, was that we actually, our VA data might have this as well, but basically looking at this question of smoking by dose. So thinking about tobacco pack years as a marker of either cardiovascular disease or damage in lupus. And we see here that Dr. Trevor Cowan on the left, who is one of our faculty here in rheumatology, and Dr. Nana Eze, who is now on faculty at Harvard, who was a student with us at the time, that when we looked at pack year smoking history in lupus, we could see that permanent lupus damage happened 7 years faster in patients who continued to smoke at a 10 pack year smoking history. So really making the point here that there's a dose dependent likelihood of having increased and earlier permanent damage to organs with lupus. And this was in the context of other lupus literature showing things that either increased or decreased risk of long-term poor outcomes. And so in this study, again, that looked at data across 12 different developed countries, we could see that there was a risk in patients of Black race, specifically in the US, which is interesting. Again, kind of that definition of the World Health Organization of a health disparity where it was not observed among patients of Black race living in 11 other developed countries. But secondly, featured in that box, we can see that risk increased with corticosteroid use, it increased with hypertension, and the risk decreased when patients were consistently on antimalarials like hydroxychloroquine. So these are some of the factors that we sought out to kind of think about as possible intervention strategies, thinking about hypertension, smoking, and antimalarial use, for instance, as we move forward. So these are just some baseline studies we did, again, many of which used EMR data to get the lay of the land. And next, I'm going to pivot and talk to you a little bit about some pragmatic studies and things that we looked at to intervene, to think about how we might help prevent cardiovascular disease. So the first thing we used was, again, looking at the evidence. And so the evidence that we used was this article from the American Journal of Preventive Medicine, then from the group from the Centers for Disease Control at the time, where they just looked at the likelihood of preventing early deaths by percent of service use. And what we can see here is the slope was greatest for hypertension, which we see out at the right here, and smoking cessation, where you could get the biggest bang for the buck for an intervention, save the most early death or prevent the most early deaths by intervening on those two data points. So that's what we did. And just for a point of reference here, you can see that, for instance, if you can improve hypertension treatment, again, you don't have to be completely controlled, but the number of people on treatment by 5%, you can save 10,000 lives. And if we look to the far right here, if you get 100% pneumococcal vaccination, so you completely ace the test there, you save about 3,000 lives. So again, making the point that things we do every day in clinic, which I vaccinate patients regularly as a rheumatologist who prescribes immunosuppression, but really that hypertension and smoking might have even greater value for longevity in my patients. And so that's where we set out to do some interventions. All right, so some of you have heard us present on this before, but the BP and Quick Connect interventions, again, were born from that effort to reduce cardiovascular disease risk and damage in patients with rheumatic disease. The BP Connect intervention specifically was just pointing out that we were missing hypertension that was sort of hiding in plain sight. So we created an electronic health record alert that would pop up if a patient had a high blood pressure, here measured at greater than 140/90. We would advise the patient, we would recheck it to make sure that it in fact was high and it wasn't just that the patient had rushed in that day. Once it was verified, we would advise them on the risk and why it mattered in rheumatic disease patients. And then we would connect them for follow-up with primary care if in fact that had been confirmed high. Our research question was whether this would improve timely follow-up of high blood pressures. And we thought we might also be able to look at that population question of whether it would improve blood pressure control across the population, though at first we weren't sure we were completely powered to see that. So we did an intervention in our rheumatology clinics that included an implementation strategy where we engaged medical assistants to co-design this process. We did an education to review blood pressure proper technique and the steps in the workflow to make it feasible within just a couple of minutes. We built in some EMR tools that would help automate those steps. And then monthly, we provided them with some audit feedback to let them know how they were doing on measuring and getting patients back to follow-up. We had two best practice alerts. The first one popped up saying, hey, your pressure is high, showed you the recent trends, told them to wait a bit and then repeat. And the second, if it was confirmed high, brought you to an order set, which you can see on the right. And in this, I'm just pointing out here that the nice thing on the order set on the right was that we nested this with what we call smart data elements, or SDEs, that were tagged. So we could actually do our reporting for the study based on the order set, where we could say, yep, the patient accepted follow-up, and the smart set was smart enough to also know that if the pressure was real high, it was follow-up within 2 weeks. And if it was just marginally high, it was 4 weeks. So again, the smart set was smart, helped execute care and also do data collection for the intervention. What we found is that we were able to double the rate of timely follow-up in primary care, and that we saw this across all subjects in the study. And when we did an adjusted odds ratio of 2.16, which was great. And then we saw that particularly patients of Black race benefited. So it looked like everyone benefited, and then there was also a disparities reduction potentially here too. The other great news was that it helped everyone, where we see on the left, the line there is just showing us rates of high blood pressure with first measurement before the intervention and rates of high blood pressure with first measurement after the intervention. And we can see that we had a 9% decline in rates of hypertension across our population, which was really great to see as well. And this prompted us to continue the intervention at UW and to disseminate it elsewhere after publication. We were able to show that this worked also in non-rheumatology specialty clinics. So here we've got Dr. McCabe Williams on the left and Dr. Heidi Brown, who did this in some GYN subspecialty clinics. And again, we're able to demonstrate that the same intervention worked in that setting. And then we were able to bring it to Medical College of Wisconsin. And again, here thinking about implementation science, one of the cool things here was sometimes you just have to be nimble, right? A traditional RCT would have had a clean washout period. Here, we wrote the grant for MCW, and in the meantime, they implemented sort of their own homebrew version where they had people making outreach calls from a call center after patients had been in with high blood pressures to try to get them back in for follow-up. And so rather than seeing that as a problem, we actually saw that as a live active comparator. And so you can see here on the right is that the MCW's institutional protocol compared to our protocol, one of the main things was that they were doing asynchronous follow-up phone calls down at the bottom there. And we were doing real-time scheduling, meaning if you came to my clinic and you had high blood pressure, we remeasured it. And if it was still high, we set up the follow-up right there at the rheumatology clinic. We called over to primary care and got you in for a follow-up. And so that's what we were able to pivot to at Medical College of Wisconsin to compare their institutional intervention protocol to our intervention protocol. And again, we were able to show improvement that BP Connect increased the likelihood, even after full adjustment, increased the likelihood of timely follow-up by 23%, and again, showed a disparities reduction. So again, these were positive results, and we've continued these interventions for many years at these sites, and we've now disseminated this toolkit with over 1,000 downloads, and we'll talk a little bit about that in a bit. Similarly, we wanted to address the issue of smoking in our population. We realized that we were rooming patients. We would say, do you smoke? They would say yes. And we would say, do you have any allergies? We wouldn't really do anything about it. So here, same intervention, check, advise, connect, same implementation strategy, thinking about engaging, educate, reminding, and audit feedback. And really, we wanted to know, could we improve rates of quitline referral? So here, the other great thing about this intervention is it took 15 seconds to just ask if patients are ready to quit, if they are identified as smokers. And then if they said yes, they thought about cutting back or quitting in the next 30 days, we then would make a pitch to send a referral to Quitline to have Quitline call them versus just handing them a card that they probably would throw in the trash before they got out the clinic. And so the great thing here is, again, 90 seconds point of care executed by a medical assistant in my clinic, which is one of the least expensive units of care provision. And we were able to study the intervention in our clinics. Again, we used a smart set and best practice alert. And the smart set had a couple of things in it. One is it had some reporting, and the reporting also came from the Quitline, which was pretty terrific. So we set up an HL7 interface. The Quitline could then result right to our EMR, and we could see if the patient was reached, if they accepted. Here we can see they accepted a 21 milligram nicotine replacement patch, and they set a planned quit date, and we've got all of that captured in our EMR, which is a slick thing for assessment of the intervention. And what we saw was that we made an impact where patients were 26 times more likely to accept a quit rate to be referred to the Quitline, first of all. And then we had over 300 referrals to Quitline. And among them, we did a follow-up study where we saw that 33% of those folks who set a quit date actually stayed quit, which was good with this low touch intervention. And at 94% of them were satisfied with the intervention. So again, at population scale, it looked like this worked. And one of the other caveats that I was able to talk with my staff about, which was really great too, is that tobacco use is again another health disparity issue where we see differences where people who have had less education or people who come from minoritized communities have higher rates of smoking. And so again, helping folks quit smoking, there's very little that I can do in my career to put $4,000 in the pocket of one of my patients. But if I can help them quit smoking, a pack-a-day smoker saves $4,000 a year, not to mention all of the health benefits. And so really this is kind of another intervention where it's both a health intervention and I would say also an equity intervention. So that was something that our MAs took a lot of pride in as well. We were then able to then what I call stress test this intervention, again, bringing it to an even lower resource setting where we went to the Grady Public Hospital in downtown Atlanta. I don't know if any of you are familiar with this, but it's a safety net hospital in Atlanta. When I first visited there, they had CDC semi-trucks in the parking lot that were treating patients with influenza that winter. Like they are the community safety net. Like they see everything, and it is a very low resource center. They have a big hospital, but they also handle all the overflow for the city. So the thought was if Quick Connect worked there, it would work anywhere. And the beautiful thing was it worked there, that when we trained the MAs, we were able to, again, increase quit referrals 20-fold. They had over 100 referrals from their center. And again, it worked in their setting. The other great thing here is that we did some cost analysis. And since we worked with medical assistants, Fortunately, their pay rate, I think, is a little bit better than it was at the time when we did the study, but nevertheless, the beautiful thing was that per referral to Quitline, at the UW, it was about $1, and at Grady, it was less than $1, and per quit attempt, it was only $15 at UW and $5 at Grady Hospital, showing this is a really cost-effective intervention where, again, we're not using MD time, we're not using nurse time, we're helping just to connect people to free public resources. And the cool thing was that the quit line, once they were reached in both of these states, would send free nicotine replacement to patients and do free phone coaching. So this was a good intervention that has been sustained at UW. We've done it also at Gunderson La Crosse. They're still doing it. And then again, the Grady Public Hospital is continuing this intervention as well. We were able to disseminate these as toolkits to do both the EMR build and the staff training. And these are downloadable at connecthealth.wis.edu. And they've been featured by the Centers for Disease Control, the AHA Million Hearts program, and again, are featured in a number of other publications and have been replicated elsewhere as well. We've got short video demos to help train and sustain onboarding staff. And this has been a kind of a fun ongoing project. Now that like set us up again, for continued dissemination and sustainment in those realms. We've continued to share this with others in rheumatology and other spaces. But the next piece that I wanted to take on as a rheumatologist was really thinking about these inequities in the field of lupus. And so in lupus, one of the great opportunities that I had was to work again with the registry of the American College of Rheumatology and also with the American College of Rheumatology in developing the first ever quality measures in lupus. And so when we started to put together the quality measures, we created a Delphi panel where we invited experts from across the country to look at data to say what interventions could we make in the field of lupus that we can measure with standard EMR data that we could look at in a registry format, where we think we actually would have a public health impact, where we could improve outcomes by reducing damage, reducing premature mortality, and improving long-term outcomes for patients. And again, going back to those early studies I shared with you, when we looked at the data, the things we chose to focus on as a group were encouraging hydroxychloroquine use, limiting glucocorticoid use, and continuing to monitor for kidney health. So those were the three things that the Delphi panel recommended out of about 20 that were considered. And the nice thing was that some of these data were data that we had looked at in national Medicare studies and elsewhere, but that we knew from the literature really could make a difference. And the great thing was that we were able to then look locally to see what we could do to improve these things. Now, some of you know some terrific work by Dr. Shivani Garg, who has looked at things like hydroxychloroquine adherence interventions and others. But one of the pieces that we had done at UW and sort of nationwide and some focus groups was recognizing the fact that hydroxychloroquine, which is a drug that decreases new organ involvement in lupus by about 40%, it prolongs life, it improves survival, decreases stroke risk, decreases heart disease risk, decreases diabetes risk. It has all sorts of amazing benefits. But that medication, the one thing you need to do to monitor it is get your peripheral vision monitored and get an eye test. And what we noticed was that at UW, it was taking us 18 months to get patients in for an eye test that was quote unquote recommended annually after 5 years. And so we started thinking about how could we make it easier for patients who have many, many visits a year to a rheumatologist, primary care, sometimes a kidney doctor if they've got kidney lupus. And then they're also then waiting to get into the eye doctor. We were trying to think of ways that we could reduce barriers and improve adherence to hydroxychloroquine and continuous use there. So we wrote a grant that was funded last year by the Congressionally Directed Medical Research Program. So that, again, formerly known as the DoD program, or a subsidiary now within that portfolio. And they specifically had a lupus grant where we proposed saying, what if we could do the eye test in rheumatology clinic? What if we could train medical assistants to do those basic eye tests, and then we could asynchronously send results to the eye professional to then result back to the EMR. And so for this study, we, again, thinking about the current workflow, we knew that what we would do is we would refer patients to ophthalmology or optometry. We would wait 11 or sometimes up to 18 months. They would go to the visit that day. And actually, what patients told us is sometimes the right tech wasn't there, and they'd have to come back for a second day to get the second study. And then the rheumatologist would have to go find those results. So if it's at the UW, that's often just in the EMR. But if they got it done at Shopco or some other clinic, community clinic, it also meant that our staff were doing a lot of running around to locate those results and help get the right studies done. Um, versus an optimal workflow where we thought, what if we could do it same day in our clinic, send it to an optometrist or an ophthalmologist to read it asynchronously, and then result it back to the patient, and really then only send the patients for a clinical in-person exam if there was something that was abnormal. And what we thought on this was that we hypothesized that we would A, improve screening, B, reduce differences by population, and C, that this would be feasible and acceptable, that we thought that the staff, and in fact, when we've done some focus groups on this, our rheumatology nurses say, anything to make it easier to do these refills, because tracking down those eye exams to do the refills is one of the least desirable clinic jobs. So they were on board with the MAs and nurses to help us get these eye exams to keep this going. So we've partnered with UW Health, with Froedtert Medical College of Wisconsin, and again with the Grady Emery group to do this study. And what we've got, again, we talked a little bit about that we're going to implement at UW, MCW, and the Grady Atlanta Hospital, looking at reach and effectiveness, looking at disparities reduction and feasibility and acceptability. And what we're using for this is we're doing cluster randomization. So we've randomized the sequence of clinics. The unit of analysis is clinic. Again, that's actually similar to BP and Quick Connect, where once you train staff, that's the unit of analysis, right, is the staff. We're doing a type 2 hybrid where we're going to study both the effectiveness and the implementation strategy in our clinics. And we are aiming to recruit 150 patients per site. And we've just gone live at Medical College of Wisconsin and the UW East Clinic here in Madison. And next year we'll do Grady and the Junction Road Clinic. Again, this is just a quick little schematic here is just showing you that this is a type 2 hybrid design within dissemination implementation or implementation research, and that we're going to look at both the effectiveness of the intervention and then the feasibility and impact of our implementation strategy, where again, we're doing these in the rheumatology clinics. And so that's just showing you the study design. The equipment, we've got a one-touch OCT on the left here, and it's pretty slick that our MAs just have to touch a picture of your pupil. They touch the pupil, and it takes the images that we need of the back of the retina. And then on the right-hand side, you can see the virtual reality headset, where a patient uses a remote control clicker to do the flashing light test for the peripheral vision visual field test. Again, we're in the process of gathering data on that right now. And while we're doing that, we actually did do this summer a baseline study to say, how are we doing at baseline here at UW for getting people screened for those tests before the intervention. So we did a retrospective cohort study. We used a REDCap tool to do abstractions. And this is Sarah Plutchuk, who is one of the M2s who was in the Shapiro program last summer, who did these abstractions. Sarah came to us noting that she had been an eye tech in a former life, and she has been a great help on this project. So when Sarah did the chart review of those 100 patients and actually went and tracked down outside records or looked in the media tab to find results, she found that 45% of patients had not had their annual eye exam in 2022, 41% had not had it in 2023. And when we looked across both years, only 35% of patients had been screened each year when indicated. Additionally, 1 in 3 of those patients actually had to come back more than once to the clinic because the wrong tech or the wrong machine was up that day. So really kind of pointing out the inconvenience of the current state of affairs. And what we found was that men were less likely to get their eye screening done. Patients who had been Medicaid eligible actually were less likely. So there was an SES effect here. Might be because of some of the screenings that were happening in private clinics on the outside. Folks who had anxiety, depression were less likely to get tested. And the only group that was more likely to get tested were patients who had diabetes, who again had another indication for needing eye exams on a routine basis. Interestingly here too, we had another data point that came out of the EMR where we were able to look at the baseline rates of adherence. So there is a SureScripts field that you can actually search in the electronic health record, where you can look at the last 6 months and see timeliness of refills, they'll estimate what they call a PDC, or a proportion of days covered. And what we found was that across those 100 patients, our mean PDC was 76%. Now, good adherence is described as better than 80%. So our average adherence was less than what was desired, as just kind of baseline here. And it really is kind of pointing out that that what we're hopeful we'll see is that as we give people safety signal and we get these timely eye tests done every year in clinic, we're hoping we can help nudge and encourage persistent, consistent use of the hydroxychloroquine medication, and also potentially nudge that adherence marker as well. So we're going to follow that here at UW. At all of the sites, again, we have a best practice alert that can order the tests that then can result right back to the EMR, which is terrific. This is a look at what they call now an OPA, or practice advisory, rather than a best practice advisory. And this just showing you the one that they have at Medical College. Similarly, we have one of these popping up at UW right now. And it, again, then gives us a place to land the result. Here you can see slices of the back of the retina that can go into our PACS system and then get asynchronously read by an optometrist and resulted back to the patient. The outcomes, again, using EMR data and data from that the system will look at how many patients we reach compared to all the patients that were eligible who had lupus, were on hydroxychloroquine. We've got some decline reasons that we can demonstrate sort of who already has had their exam versus who needs it. We'll be able to look at effectiveness, again, looking at whether we get completed screening within that calendar year versus the folks who just go in the queue for regular eye exams. We'll be able to look at adoption rates among patients and staff. We'll look at implementation fidelity. In other words, are the staff able to get readable results versus trained optometry specialists? And then we'll be able to look at maintenance over time. So again, this is using that re-aim framework that some of you are familiar with. And this is one of my favorite, again, evaluation frameworks that I really highly encourage anybody who's not familiar with that to get familiar with that. The second one is that we'll be looking at screening rates by groups at risk for disparities, by race, rurality, and area deprivation. Again, to look at which might correlate with things like access to ambulatory care. There have been some studies recently showing that, again, distance to optometrists. I saw a recent diabetes study saying that distance to the nearest, even just optometrist in some areas, is around 100 miles, which is kind of wild. So again, and distance to ophthalmology even greater. So when we think of the United States, so again, just considerations here on whether having it nested right in their rheumatology clinic where they're already coming might make a difference here for folks. And then finally, we'll be able to do some mixed methods and do some intervention or some interviews of our staff and patients to think a little bit about how well this was acceptable and feasible for patients so that we could disseminate this in the future. So again, I told you about a number of different, both descriptive EMR studies and then interventional EMR studies, including some that were pragmatic trials at multi-sites. And I just wanted to bring it home by kind of talking a little bit about some of the lessons that we've learned over the last decade or so of doing these studies. One lesson is that we are realizing that we often have to sort of educate the IRB a little bit, that these are standard of care interventions, right? So follow-up of high blood pressure should be happening anyway. Eye exams using FDA-approved tools should be happening anyway. So we've had to educate a little bit on these as pragmatic studies. We're saying like, the unit of intervention is actually that we're training staff to do these studies, but they're not experimental interventions on the patients per se. We're just looking at population level outcomes. The second thing is we've had to figure out how to scale EMR builds where we can build it in different centers. You heard about a lot of different Epic using systems. And so again, we're grateful here at UW. We've got the CURDS group that's helped us with several builds. We've been able to create toolkits with graduate students and others so that we can replicate those builds when we do this in other sites. We've had to learn a lot about data harmonization, and some centers have, robust CTSA and PCORNet type data models that are really helpful. Other places we have to sort of get them a data dictionary and help them create those data pulls or have them send us the data warehouse tables from their Epic with pseudo ID so we can create a harmonized data set across those sites. We've learned that one epic instance is one epic instance. So again, you have to kind of know that the nuances are a little different from epic to epic. And then obviously there's different contextual factors, which in our case, are helpful in the case of like the Grady setting where we can stress test the intervention and see if it'll work even in a low resource center, for instance. We've also identified a few opportunities, and this is where a little bit of a soapbox here for the clinical trials group here at UW. The single IRB here, we had to give them a little bit of education on D&I and standard of care studies. And we also had to educate the local IRBs for our partner sites and would really encourage anything we can do to get the word out on the importance of these studies as we think about learning health systems and learning health specialties. Really vitally important that the IRB understand the importance of these studies and that, again, none of these are real threats to patient safety or autonomy. And so really kind of getting the word out on that can be helpful. We've also had to navigate where we're kind of walking the line between what's research and what's clinical care. And, any efforts we can do here at UW to reduce duplicative clinical approvals, committees, or prep to research for these things, I think, again, would be really high yield. And then finally, one quick plug here is that, systems like the Mayo Clinic and others do opt-out consent for all their patients. They basically say you're going to be included in our Rochester epidemiology study project unless you tell us you don't want to be. And patients generally don't have any issues with that. And I would love for UW in the future to maybe think about a standard opt-out EMR data consent. But again, that's just a bit of a pipe dream, and just kind of tossing that out there as food for thought for this group. So essentially, when we kind of come back to it here, we've talked a little bit about the role of pragmatic studies. We've talked some specifics about our RA and lupus studies, and hopefully you can envision where you might be able to use pragmatic studies or implementation science to think about how you could impact clinical populations that you care about as well. And with that, I'm just going to thank a number of different collaborators and partners on this work. I'm sure I've missed some people, including I'm seeing some familiar, fabulous names on the call here today. So I hope I have not missed you if that's the case, but it's been really fun to do this sort of team science. It's been fun to be able to see it scale on the national platform with the American College of Rheumatology. And we're deeply grateful again for our funders. In the lower right, you see I'm also deeply grateful to my fabulous husband who helps with our 2 teenage kids and has been an amazing partner in life. And I'm going to leave us actually with just one quick quote here, which is one of my favorites. It just says, it's from Louis Pasteur. And he said, to a person who devotes his life to science, nothing can give more happiness than increasing the number of discoveries. But his cup of joy is full when the results of his studies immediately find practical applications. And it's been really fun to be able to do research that has some immediate practical applications. And so with that, I will pause and take your questions.
Thanks so much, Dr. Bartels. We have a question in the chat. I don't know if you're able to
Oh, I
see
see it
it.
here.
Okay.
I love it. So Great Talk says, what would prevent UW from doing something like the opt-out consent? Have I brought this before? I have brought this up a few times. So I sit with Jamal Matthew on the Data Science Collaborative. Used to be with I'm at any rate, so I have brought this forward a few times, and I would encourage. I'd say maybe we all need to be groundswell to encourage this. I think this is something we should definitely think about in the future here at UW. So any platforms that you have to promote that idea, I will continue to promote it as well.
Other questions for Dr. Bartels today? You can either put those in the chat or because we have a smaller group, you can unmute. Just ask your question.
Hi, Dr. Bartels. This is Shannon Casey. Thank you so much for your amazing presentation. I am curious if you could say a little bit about how you strategize working with systems to obtain these data. So presumably you're getting permissions or buy-in from multiple people at multiple layers of administration or organizational levels. So could you just talk a little bit, please, about some success strategies you've had for buy-in and
I love that. Okay, so I love that question. So first of all, Thank you for the kind words. And what I would say is, a couple of things that have been really successful. I think one is I bring a different pitch to the clinical operations folks than I do to the research folks. That basically I think of what the win is for them. So the win for them is to improve their clinical outcomes and improve their, WCHQ data standings or things like this. So I bring their own data to them and tell them how this might actually benefit them and how we can bring resources. So I go well in advance of the grant deadline. I tell them what we need, and then and that helps. And I find a local partner in, like, as you saw in each of the rheumatology clinics. So I've got a
Mhm.
local physician champion. I've got then usually a clinician champion in the sort of leadership cascade. And then I usually find a data partner, often through the CTSA. So Shannon, like Medical College of
Okay.
Wisconsin, there's a woman named Kristen Osinski who's just been fabulous. We get data use agreements together at Marshfield Clinic. I've worked with Bob Greenlee extensively, again, get data use agreements together, work through their IRB. And then it's the beautiful thing is, and then we've got similar partners at Grady now, and at Gunderson. And once you get a data partner and you work well as a partner, you get your DUAs in, you get your
Mm,
IRBs in, and you send good data dictionaries. You show yourself as a proven, trusted partner. And then when you come to them with the next study, they often are game to say yes. So I'm happy to share some of those contacts. But I think, again, CTSA connections can be really helpful. Your clinical partners can be really helpful. And then always think of it as like, what's the win for the person you're pitching to, right? That the pitch has to be
right.
a little different for each audience.
Great. So pitch and partnership. That's
I
really
love it.
easy to remember. Thank you
That's
so
good.
much.
Thanks,
Okay,
Shannon.
thanks.
Anything you would add to that?
No, except for Majid Afshar, who's just a
Yeah.
rock star in this area,
Yep.
has talked
Yep.
about kind of exactly what you're saying about what's the need, what's the goal, and so how do we get to the gap? So or through
Yeah.
the gap.
Yep.
So and you only do that in partnership of
Yeah.
what's our need, what's our end goal, and what's my ask of you. So yeah, that maps right on. Thanks so
That's
much,
great.
Christy.
Yeah, absolutely. Thank you, Shannon. I see a question here from Craig Comfort. It says, what did you find as a typical time to build a BPA? What did you learn that others could use to streamline tool development? Yeah, this is great. So I will tell you, there's two different, actually there's a different range of BPA builds. So I would say that BP Connect build can happen in a day. Actually, Gunderson built it in like a day, versus the Quick Connect requires an HL7 interface test, and that takes sometimes like a week because it takes a lot of back and forth testing and you need some nuance. So it depends on the BPA is, I guess, the first thing I would say. But to get all of your approvals and your get in the queue for a build, your most successful, I would say, if you come with money so that you can go through like CURDS and you can get in the research queue to have their builders build it. We've had really fabulous success with that, and I'm deeply grateful to that team. So I'd say, we got on their radar. You submit the grant 9 months in advance and you let them know that you'd like to do this. As soon as you get notice of award, you let them know. And I will tell you that for our most recent grant, so we knew we needed to build at 3 sites. We actually gave ourselves an entire year to get through IRB and build prep. We knew we wouldn't go live until 1 year into the grant. And I would say, again, giving yourself plenty of lead time and being really realistic about that is incredibly important. So like it's the time to build it versus the time to just get in the queue and get all your approvals. I would say give yourself, yeah, close to a year. It takes time.
Okay. Are there other questions for Dr. Bartels?
Monica Messina, who is my fabulous lab manager, is on the call here too. And Monica, would you add anything to the plan a year in advance? Any other comments that you would add?
I think what we came to realize with the eye exams is there are other systems we don't know about.
That's
So
true.
allowing for more people to be called in if necessary and have the time to do that.
The beta testing, yeah. When you're
Mhm.
looking at with technology, there's always beta testing. Yeah, that's great. Thanks.
I'm curious, have you received any feedback from either the patients or the medical assistants about this new approach? And it's almost like a one-stop shop for some of
Yeah,
the interventions the tests that they need.
yeah. No, I think this is great. So, early with BP and Quick Connect, I will tell you one of the surprise benefits was that actually a lot of our MAs told us this is one of the first times they had participated in QI and one of the first times that they got their own individual data to see like that they were making a difference and they felt really positive about participating. So like that was an unexpected benefit, which was really cool, is that we elevated the professional perspective of those health professionals in our clinics, which was super cool. The second piece would be on the eye exams and things. They're kind of excited about the technology, like you're saying. And then the other pieces like that I mentioned is that when we did focus groups to create the workflow, we again listened to where their pain points are. So they've got a lot of, I see Yao on here too, that it takes a little bit to train them that to do the eye exams, but since their pain point was tracking these darn things down in the community, which is a pain in their tuchus, they were highly motivated to say, yeah, let's try to figure out how we can solve this here locally to help it make it's better for patients, it's better for us. Let's do this. So I think that's the power of doing focus groups with a little incentive and a lunch. You really make partnerships that's those two P's, right? You make partners with the people who are the end users for the product too. So those are
Oh,
great.
that's great. Okay, I'll do one last ask and see if we have anyone else with a question that they want to share with Dr. Bartels. I think we're good.
Well,
So
thank you everybody for your time today. I really appreciate it.